When most people, including some doctors, think about TRT and blood clot risk, they think about one thing: high hematocrit, thick blood, the sludge effect that happens when too many red blood cells are circulating. But what if I told you that's only half the story, or maybe in this case, a third of the story? And it's not even the most immediate danger when you're starting TRT. There's separate hidden risk that has nothing to do with how thick your blood is. It has to do with the stickiness of your blood, and you can test for it before you even start your first injection. Hello and welcome. My name is Dr. Taranell, and I help patients navigate these complex hormonal protocols in different scenarios every day. And to do this safely, we have to move beyond just a single lab marker of your testosterone and look at specific biochemistry of why a clot happens to begin with. It's not magic, it's mechanisms. Okay, so the first thing to really grasp here is while we've all been trained to focus on the long-term viscosity risk, the sludge and the high hematocrit with TRT, the real immediate risk for many men is more chemically based. And in this case, I'm talking about fibrinogen. Fibrinogen is the raw material for clots. It's what makes the blood more sticky. And if you already have high fibrinogen from hidden inflammation, things like insulin resistance, metabolic syndrome, or just increased body fat, you're at higher risk for having a clot. Then you go on, add TRT, even a standard 100 milligram a week dose, and it further increases your risk. In a susceptible person, it's a new variable in an already pro-thrombotic state and a pro-clotting state. And this added risk from TRT is present from day one, even when your hematocrit is actually normal. This is why a one-size-fits-all is so dangerous, and we cover how to assess your levels and some of these risk factors in my new ebook, Mastering Your TRT. And for those looking to find more of their optimal testosterone dose, you can check out the app as well. There'll be links to both in the description. All right, so we're going to look at 3 distinct but specific clotting mechanisms. The one everyone knows about, the one everyone misses, and the one that happens when your levels just are a bit too high. So the first one is the one that everyone talks about, and I've talked about on this channel before, and that has to do with your testosterone stimulating your kidneys to produce more hormone called erythropoietin, or EPO. EPO then signals your bone marrow to produce more red blood cells. And this is why over time, your blood literally gets thicker and your hematocrit goes up. When you have too many red blood cells in the same amount of plasma, the same amount of water, your blood becomes more viscous, or it slows down. This makes it mechanically harder for your heart to pump and physically easier for things to slow down enough where it can actually form. And this is absolutely a long-term risk you should be following and watching if you're on TRT. But it's also a risk that comes on only after you've been on it for a while. It takes 4 months, 6 months, sometimes even 18 months for the hematocrit to be high enough for it to be an actual problem. It's not a risk in month 1, 2, and 3 for most people. So if it's not coming from the increased hematocrit in the first 6 months, what is it? And that's a pre-existing condition that I mentioned. This is reason number 2 for increased clotting risk on TRT. So the second risk that's often missed, and it's all about looking at your baseline levels. An acute phase reactant is a clinical way of saying that your body is inflamed. When it's inflamed, it makes more fibrinogen. If you have insulin resistance, high body fat, chronic stress, autoimmune disease, your fibrinogen is probably already high. And so you're starting TRT in a pro-thrombotic state. Your body's just waiting to clot. Then you add testosterone in, and while the testosterone can be anti-inflammatory in the long run, you're adding a new powerful variable to a system that's sensitive to any margins for error. This is why we should be testing for fibrinogen at baseline if you're going on testosterone. It's a primary risk marker that tells us who needs to be more careful and who needs to fix their inflammation before starting therapy. So that's all good if you find it, but what if your fibrinogen is normal, your hematocrit is normal, but your dose is just too high? Or more importantly, your level of testosterone is too high. This is a different ballpark entirely and gets into totally different mechanisms than we've discussed. This is what we see in the research on supraphysiological doses of testosterone. Supraphysiological means it's just higher than what your body would naturally produce, higher than what we typically see in a normal adult male. But here's the important thing to distinguish. One person can take 200 milligrams a week and have a total testosterone of 700, 800. The next person can take 100 milligrams and be at 1500 plus. So it's not really the dose that you inject, it's the level in your blood, in your body, that really matters. Whenever your levels get really high, say 1200, 1500 milligrams per deciliter, your body's elegant balance can start to break. And that balance is your body's not just producing clots randomly, it has the ability to also dissolve them. And this is called fibrinolysis. But research on supraphysiological levels of testosterone shows that it can actually flip this system and break the fibrinolysis process. And so it mutes the dissolve signal that's naturally there and suppresses the key molecule called tissue plasminogen activator. This is the main go signal to the body to start to dissolve a clot. And not only that, the clot itself actually gets harder and tougher to break down. And this is from an increase in a specific clotting factor. So it's like rebar in concrete, making it harder to break up. The result is your dissolve signal is weaker and it's a more dense fibrous clot that's harder to break down with this chemically reinforced brick-like structure. So this is a very real risk because some people are on that edge of being at 1500 plus certain points in their testosterone weekly dose. And it's separate from both the high hematocrit and baseline fibrinogen levels. But sometimes people have all three going on at the same time. The bottom line is that your clot risk on TRT exists on a spectrum. Yes, there's long-term high hematocrit problems, but there's an immediate risk from the stickiness of fibrinogen from underlying inflammation. And then there's a separate impaired braking system that happens when your levels are just way too high. This is why it's important to accurately assess your baseline labs for things like fibrinogen, just general inflammation, before you start. Balance is key for just about everything, and that especially is true for implementing a TRT strategy safely. And since mostly this depends on your actual blood levels, not your dose, you need to know how to test properly. And I explain the exact process, how to test your peak and your trough to find the best testosterone levels in this video right here.